Welcome to Kwaderno Academy, empowering excellence through education. Join us as we inspire growth and unleash your potential. Let's dive in.
Welcome to The Explainer. I am so thrilled to have you here today. We're going to be taking something that, honestly, usually puts people right to sleep, those highly technical Medicare payment rules, and we're translating it into simple, actionable, plain language. Specifically, we're zooming in on the Speech-Language Pathology Case Mix Index, or SLP CMI, under the patient-driven payment model. So get ready, because we are going to completely demystify this whole process together. Now, I want you to really think about this for a second. Are you accidentally hiding your residents' true SLP needs? It happens literally every single day in skilled nursing facilities. Undercoding doesn't just lead to lost facility revenue, though let's be real, that is a massive issue. It critically fails to reflect the true clinical care burden that your team is managing for that resident. If your documentation doesn't tell the full story, the system just assumes the need simply isn't there. Okay, let's dive into this. We've got a quick 6-step roadmap today. We'll define the need score, unpack the SLP backpack, calculate the group, look at real resident examples, tackle common pitfalls, and wrap up with a practical team checklist. All right, first up, the SLP need score. To really wrap our heads around this, we've got to completely shift our mindset away from that old idea of a single overarching therapy score. Under PDPM, the resident is placed into separate payment groups, and the SLP CMI is effectively a need score. It describes how much SLP-related resources a resident requires, like managing a new stroke, trouble swallowing, or trouble speaking, rather than just tracking how many therapy minutes they actually received. It's a payment classification based entirely on your minimum data set, or MDS, and diagnosis coding. A higher index simply means the system recognizes the resident has greater, more complex needs. And just consider the massive variance in these numbers. The lowest SLP CMI is SA, sitting at 0.64. The highest is SL, soaring all the way up to 3.98. That multiplier variance is absolutely huge, and it establishes the incredibly high stakes of getting your documentation right. If you miss key clinical characteristics, your resident might be sitting way down at a 0.64 when their actual clinical burden requires a much higher classification. Moving right along to Section 2, Unpacking the SLP Backpack. So let's see how this builds.
We're going to use a brilliantly simple analogy to anchor this explainer. Think of the SLP score kind of like sorting a backpack before school. You have to ask yourself, how heavy is this resident's SLP backpack? By taking all that heavy CMS jargon and turning it into physical, relatable items that we literally have to pack into this bag, we can easily visualize what goes into accurate classification. Some backpacks are going to be very light, and some are very heavy.
So what exactly are we packing? Well, PDPM looks for 5 specific clues. The first 3 clues are what we call the condition count. First is the main reason for the stay an acute neurologic condition, like a new brain or nerve problem. Second, is there an SLP-related comorbidity? We're talking things like aphasia, a stroke history, or maybe a tracheostomy. And third, is there cognitive impairment? Meaning, does the resident have trouble with memory, thinking, or decision-making as captured by the BIMS, the brief interview for mental status, or a staff assessment? Then we have the final 2 clues, and these are actually checked together as a pair. 1, is there a swallowing disorder? Does the resident pocket food or maybe cough and choke? And 2, is there a mechanically altered diet? Are they receiving chopped, ground, or pureed food? When CMS looks at these last 2 items, they're checking to see if the resident has neither of them, either of them, or both of them. Step 3, calculating the SLP group. Now, what's really interesting about this matrix is how it takes the specific items we just packed into our backpack and sees how they translate into a definitive payment classification. The sheer logic of it instantly scales things up. If a resident has a count of none for the first 3 conditions and neither a swallowing disorder nor an altered diet, they fall into group SA. That's our 0.64 multiplier. But jump down to the bottom row. If they have all 3 of those first conditions, plus both a swallowing issue and an altered diet, they rocket up to group SL with that massive 3.98 multiplier. Simply put, the more items in the backpack, the higher the group. Section 4, Real Resident Examples. Let's look at the extremes of this logic using real-world resident examples, just to illustrate the real-life stakes. First, we have resident A. They were admitted after heart failure, they're alert, eating a regular diet, absolutely no swallowing signs, their backpack is completely empty. No acute neurologic condition, no cognitive impairment, neither swallowing nor diet issues. They correctly land an SA at 0.64. Now compare that to resident F. Admitted after a stroke, has hemiplegia and aphasia, a BIMS score of 10, which shows cognitive impairment, coughs at meals, and eats ground meats. Wow, they have all three first conditions, plus both swallowing and diet issues. Their backpack is incredibly heavy, appropriately landing them in SLL at 3.98. The coding maps directly to the resident's reality. All right, step 5, avoiding common pitfalls. But what happens when the reality doesn't actually make it to the MDS? These everyday facility errors cause teams to accidentally undercode a resident's true needs. First, the SLP note might clearly say dysphagia, but MDS Section K is left totally blank. The logic depends on Section K, so that data is just lost. Second, coughing with medications. The MDS includes coughing when swallowing pills, not just food. You've got to ask your MedPass staff. Third, failing to capture a mechanical soft or pureed diet as mechanically altered. Fourth, and this one is huge, missing cognitive impairment because the resident seems socially pleasant during a casual chat. You absolutely must use the actual BIMS score or staff assessment rules. And finally, a documented stroke history from the hospital gets lost in transfer and never makes it into the MDS. So the crucial takeaway here is if you miss these details, vital items fall right out of the backpack. Section 6, the practical team checklist. We want to give you a direct, actionable checklist that your interdisciplinary team can use before locking any assessment. Don't view these as abstract errors. Treat these points as mandatory questions you must ask yourselves. Does the primary diagnosis map correctly? Are comorbidities like aphasia or a trach properly coded? Does the BIMS actually show cognitive impairment? Are there any signs of swallowing difficulty, even just with pills? Was the resident on an altered diet during the look-back period? If the answer is yes to any of these, your MDS and supporting documentation absolutely must match. To tie this whole shebang together for your facility, keep this practical teaching phrase in mind. Seriously, print it out and put it right at the nurse's station. If it affects speech, thinking, swallowing, airway, or diet texture, check whether it affects the SLP-PDPM story. It's the perfect reminder for SLPs, nurses, dietitians, and MDS coordinators that accurate CMI requires absolute teamwork. Which leaves us with one final vital thought to ponder. Is your MDS actually telling the full story? Remember, this isn't about inflating payment. It's about making sure the real, complex clinical needs of your residents are not hidden from view. Take this knowledge, review your own documentation processes, and make sure every single item in that backpack is accounted for. Thanks so much for joining me for this explainer, and keep up the great work.
Brought to you by Kwaderno KO. Learn smarter, not harder.